I'm bringing this committee to order, please. Good afternoon and welcome to the Assembly Committee on Health and Human Services. Would the Secretary please take the roll?
Assemblywoman Gonzalez. Assemblywoman Gorlow.
Here.
Assemblyman Gray.
Here.
Assemblyman Hafen.
Here.
Assemblyman Hibbets. Assemblyman Koenig.
Present.
Assemblywoman Newby.
Here.
Assemblyman Wynn.
Here.
Assemblyman Orentliger.
Here.
Assemblywoman Taylor. Assemblywoman Thomas.
Here.
Chair Peters.
And I am here. Please mark Assemblywoman Gonzalez and Assemblywoman Taylor present and the others present as they arrive. Today we have a presentation on public health and public health infrastructure in our state. This is another complex topic area with many players. And I encourage you all to ask questions while we have these experts in the room. Really is the best time to get some of your foundational questions answered is when we have these professionals and experts in the room. Before we begin, though, I would like to go over our housekeeping items. Everyone's been through these, but I think it's nice to just have the reminder. I apologize if it's patronizing, but sometimes we forget. Please make sure that your electronic devices are muted. That includes laptops and cell phones. Members of the public may testify in a couple of different ways. We will have public comment towards the end of the meeting. You can submit public comment in writing also, and we will accept public comment submitted before, during, and up to 24 hours after our meeting's adjournment. If you wish to testify in person, please sign in at the table by the door and leave your business card so we can keep an accurate record of who's testifying and get your name spelled correctly. Anyone who would like to receive electronic notifications and access to the committee meeting material, you can do so by signing up for Nellis. That's our legislative online service there. To ensure an orderly flow of discussion, all comments, questions, and responses must go through me. Committee members must be recognized before you can speak, please. Additionally, I ask our presenters on the Zoom video call to leave your cameras off and microphones muted until it is your turn to present or if I direct any questions to you. When testifying in person, please turn on the microphone to speak and off to listen because we get feedback otherwise. And with that, we will move on with our agenda. Today's agenda includes an overview of public health and public health infrastructure in Nevada. Maybe the presenters please step forward. We have several folks here today, some from the state, some from local bodies. I believe we are starting with Deputy Administrator Julia Peak with DHHS, and I see Megan Kumlasi and Kevin Dick. Please go ahead when you're ready.
Julia Peak for the record, Division of Public and Behavioral Health, and I serve as one of the deputy administrators for the division, overseeing several of the public health programs, but certainly not all of them. First, I want to thank you, Chair Peters, for letting us have the time today with the committee to present. It's a lot of information, so we'll probably talk pretty fast, but happy to answer questions as well. And many of you new legislators already had some snippets of this presentation, so apologize for the duplication, but I think it's helpful. So we're going to start off with what is public health. Often public health gets confused with clinical care, which is normal. Clinical care is different though, and it does focus on the individual's health. Personalized health plans and interventions for the individual to improve their health or the health of their families. Individual assessment of risk for that individual and then trying to get them on a better path personally. Versus what we do in public health, and we have a much bigger focus. We focus on population health. We look at how to reduce risk of chronic conditions of the entire population. We also have a broader scope in that we look at environmental health factors as well. So clean air and water, safe food, prevention and risk of disease or infection. The next slide is adapted from one I've provided in the past that we called the Easter egg diagram. And this one I personally developed just with folks we worked on with COVID. And just so you know, the public health system, we're often the convener or the one that brings folks together to make population health change, but we might not be the doer. And so in this diagram, you'll see that we partner often with nonprofits in the community. We don't have to deliver the services. They often are the better messenger of the message. Behavioral health providers, faith-based organizations are a great partner to us. Tribal partners, elected officials, transportation. You saw this with COVID, trying to help people get to vaccination services or clinical care. Social services, clearly, as we look at reasons that people have certain outcomes, the access to social services and private health care are things we look at. Laboratories, coroners, correctional settings, etc. Those are all partners that we might use in different situations to try to impact the population health. Next slide is just the scope of public health. Broadly and generally, we could say we understand or try to understand why people get sick, which is morbidity, and or pass away or die, which is mortality. Said slightly nicer, we want to understand how people can live the longest, healthiest lives possible. So once we understand why people are getting sick or passing away within our community, we look at strategies to try to reduce that. You often hear public health refer to upstream. So we try to go upstream to understand the risk factor that's causing a certain outcome or risk factors. And then we look at developing interventions to try to reduce the risk for the individuals, ultimately changing the population health. We have an extremely broad and flexible scope and responsibility because there's any number of reasons why people could be getting sick in our community. Public health systems, I believe Director Whitley spoke about this when he presented to you as well. We often function in the background. You don't necessarily know we're doing something until something breaks or goes wrong, and then folks see the public health system and our workers. This happened with COVID, where our capacity was reached, and so you saw public health in a number of capacities that perhaps you didn't know they were working in the past. One of the things that's happening really nationally now is looking at foundational public health services, and the way we look at this in Nevada is to ensure that regardless of the geography of somebody in our state, that they have foundational public health services offered. And then when I talk in later slides, the entity providing public health services to your residents may vary. There's many of us who are doing various things in your community, but we want to assure that the foundational public health services are being met. Not easy. So foundational public health services are really set by our federal partners. One of the things they most recently did is add equity as an 8th addition to the foundational capabilities, and I think for various reasons they did that in 2022, primarily around COVID, and just the illustration of how inequities caused different health outcomes. So equity really encompasses all the foundational areas. So foundational areas are really activities, efforts. And so you saw what we did with communicable disease, chronic disease and injury prevention are other things that we do, environmental public health, maternal, child, and family health, and I think Director Whitley's talked about that prior as well. And then access and linkages to care, though often not providing that direct care within our walls. Foundational capabilities, that really outlines the infrastructure needed to provide services in those foundational areas. And so some of the things that we assess in this area are assessment and surveillance of data. Again, if we don't understand what's happening in our population, then we can't assess how we're doing. And course correct if needed. Community partnership development. Equity, again, is the 8th newest addition. Organizational competencies, and this has a lot to do with what all of us are moving through with public health accreditation. As like a hospital or a facility that gets accreditation, they assess our ability to organizationally respond. Policy development and support, accountability and performance management, emergency preparedness and response and communications. And I do just want to acknowledge Washoe County Health District's efforts in this area. Mr. Dick will talk about it in a little bit, but his team is truly, I'm going to say, leading nationally in the areas of foundational public health services. It relates to understanding staffing capacity in these areas based on your population and your need. What does staffing look like? Because often we'll come to you and say, we're underfunded, we can't meet the service, but you actually need tangible information. Well, how many more staff do you need to meet the service to the capacity that you think are necessary? And truly, Washoe County is leading the way in that to help us develop some matrix. So public health in action, you all saw it play out during the COVID pandemic, but you might not have necessarily seen everything. We had so many teams working nonstop. So planning and preparedness, these teams really assured integration with emergency management locally, which was huge in this response. They also worked hard to get PPE to the locations necessary so we could deliver services. Epidemiology and laboratory capacity, that one's pretty clear, but this team looked at ensuring that we got lab reports, we were able to test people, and that based on that data, we were able to follow up with individuals. Analytics, I think you've heard this again with Director Whitley's presentation. Our Office of Analytics is phenomenal, and they, during COVID, provided us so much data, but they do this beyond COVID. Environmental health, this team really helped us look at safe events when we started reopening, safe food delivery, infection control and cleaning, immunizations, obvious. Immunizations really changed the course of COVID. Healthcare licensure, this is pivotal to ensure that the delivery of healthcare services in our community are safe. This team, I just want to call out one in particular, though the entire team truly moved mountains. Our medical laboratory team is a small but mighty team that was able to get testing sites stood up so that specimen collection was had fidelity, and that those lab tests in our state were performed well. So the Healthcare Quality and Compliance Bureau is really heroes that aren't seen publicly as much as the rest of the teams. Chronic disease and wellness, this team really carried the water when it came to health equity efforts. They looked at working with community-based coalitions and trying to understand how best to deliver services, and that was everything from testing resources to masks to vaccinations, et cetera. So that group, along with the Office of Minority Health and Equity, really helped the public health in that area. Access to healthy foods, and more broadly, just working with our community-based organizations, faith-based organizations, to make sure that folks during COVID had access to the services needed. That was very difficult. I like this illustration. It's called the social ecological model because it helps us understand how we can influence and move health indicators. And so often in primary care or in direct service care, you focus on the work of the individual and perhaps interpersonal, the family and peers of the individual, and how you can move that individual to better health. What we look at in public health is really like organizational and up. And your efforts for this body are really the policy, the orange outermost layer. And so our organizational change is workplace, culture, societal, falls in community and policy. And so you saw this impacted when we did things such as mask mandates and that policy change at the largest level. This, for public health professionals, is a way we understand how to impact change and maybe the best opportunity to intervene and where to intervene. So Nevada. Public health agencies in Nevada are very diverse. Nevada is only one state that are considered largely decentralized public health entities. It's us in Texas, meaning that the bulk of the population receives their service from a local health department, but we are not completely decentralized, as the state public health department does provide services primarily in our rural communities. Again, us in Texas are the only ones that still remain on that model. So we are the state public health agency, the Division of Public and Behavioral Health. We did merge many years ago and took on, we were the health division and merged and took on some behavioral health services as well. We do have several local public health agencies that will be presenting after me. That includes the Carson City Health and Human Services, and they're considered a county health department, Southern Nevada Health District, Washoe County Health District, and our newest Central Nevada Health District. Administration of public health is largely defined in Chapter 439 of NRS. I've defined some highlights of that chapter. Much of the work is done by the state public health and chief medical officer as far as oversight and assurance and regulation changes and those things. But we do have requirements for county boards of health, health districts, city boards of health, and that's all defined in that statute. We do, during the Great Recession, there was assessments placed on the counties to provide some funding to support other sections within NRS related to environmental health and infectious disease response and a few others. So local governance at the county level. Every county is required to have a board of health and a county health officer. If they fail to appoint one, the chief medical officer will appoint that county health officer on their behalf. They must oversee the sanitary conditions, adopt regulations, and they may do other things, though not mandated, and that includes working on isolation and quarantine and other things. What we moved through this last interim is developing our first rural regional health department, and the Central Nevada Health District team will talk about that in a little bit. But what this process included was outlined in NRS 439, but what it basically what required to do is they moved to offering local public health services, and so they had to remove this section of NRS where they would pay us assessments to do that on their behalf. The governor approved it and the IFC approved it as well. And so come July 1st, they'll no longer pay assessments for services and will no longer provide it. They'll provide it themselves. This is a great model, and it's regionalization of 4 counties that came together and said we're like-minded and we'd like to provide this service locally. This is good because when a single city or a single county chooses to offer services individually, it does create scale issues. We have very limited funding, and when you start breaking that federal funding or limited state general fund up between counties, especially with demographics, you can get some of the smaller counties that could have 1 FTE funded out of 10 different funding streams. And so that individual will not be able to get much work done besides grant reporting. And so what else has to happen with regionalization is the county health officers and the county boards of health have to agree to basically dissolve to go up into the regional health authority. They develop a district board of health and a district health officer. They also must develop regulations, and there's a slightly greater duty in public health to protect and promote public health in those areas versus the limited things I provided on the earlier slide. We've had 2 longstanding health districts in Nevada, and they're both going to talk to you in a minute. I've noted them there. Central Nevada Health District, as I mentioned, is the first regional rural health district to be established, and they officially became established on December 3rd. Carson City Health and Human Services is a county health authority, and they have many delegated services on behalf of the chief medical officer, so they do a great deal locally, and they do it well, but they're not a district health authority. They do provide services, again, through delegation for Carson City, Lyon County, Douglas, and Story County for a variety of services. There are a lot of challenges as we move forward with the model of creating health districts. There are different, within that statute I mentioned, different requirements based on population size. Really, Clark County has guidance within the NRS, and then every other county falls in the population less than 700,000, and it's different. One of the things that you'll see come forward as far as policy changes is to continue to promote the ability for the rural-regional merger of county health boards, and in SB 118 you'll see us requesting the word adjacent be removed in case counties want to work together and don't happen to share a border. So what did we learn from COVID as far as infrastructure? As I mentioned earlier, we're often the convener, not the doer. Our staff is very small and lean, and we often have to work with partners in order to assure that the service is delivered to the resident. So that means constantly building and rebuilding those relationships. I'd say those relationships right now are the strongest they've ever been because COVID forced us to work together. That had to do with working with schools and school districts, working with our emergency management partners, working with private healthcare to do things differently, businesses, et cetera. We do suffer from categorical federal grant funding, and I say suffer from because it really challenges our ability to be flexible. We get those grants and we work hard to meet the deliverables of those grants, and those do affect our residents positively when we could get those monies, but there's a lot of gaps. I'll just give you an example of a challenge we've had is when monkeypox hit, and we were working really hard to get vaccination information out there, to get people vaccinated, to get information out. We had no money to do that, and many of our categorical federal grants specifically would not allow us to use that staff for monkeypox. It was for COVID, for example, and we said, well, this is infectious and just as scary, so we'd like to use it. Couldn't use it. However, CDC just let us know that we'll be funded about $500,000 for monkeypox prevention and intervention. We'll go to IFC in April to ask for permission to use that funding, but if you look at the epi curve of where we're at on monkeypox, luckily, we're on that downhill curve. And so when we don't have flexible funding for public health, we wait until our federal partners are able to give us money for that topic, and it's often late, just the way Congress and money gets out to our local partners. Also, having a hybrid, largely decentralized system is difficult. Also, when many of us, specifically in the rural counties, could be delivering services to a single county, we just have different authority to do it. That could be challenging for the residents to understand. Also, the fiduciary responsibility, and this really applies to the state, I would say, but certainly the locals as well. We received over $400 million in COVID-related funds, with not a huge increase in staff to get that money out. And one of our major roles is to make sure that gets out and the deliverables are met with fidelity. And so we need much more administrative support in that area, and that challenged us. And also the importance of informatics and information technology. Prior to COVID, many of us were still working on fax machines. We would have case reports mailed. When COVID hit, we had to quickly get funding to modernize our systems, and we're moving through that process now. But that hugely limited our ability to respond. The last slide I have before I turn it over to my colleagues, you already had a quick overview on this when Director Whitley presented, but it does have population health data for your county, so I encourage you and the folks watching to visit our data dashboard on health profiles. It provides a number of indicators by legislative district all the way to county so that folks can understand within their county what's really affecting the population health, and that data is empowering and can help you make decision about interventions. So with that, I am happy to take questions, or I can turn it over to my colleagues if you'd like those to wait.
I'm going to see if the committee has any questions directly to you. I have two folks. Assemblyman Nguyen, please go ahead.
Thank you, Madam Chair, and it's good to see you. I've got the fortunate chance to work with Administrator Week many hats ago in the public health space, so it's great to see you sitting in this role, so thank you. Just kind of curiosity when you talk about foundational areas earlier, even though the division is public and behavioral health, I didn't see a specific listing for mental health, because I know that this is kind of like, I know it's obvious, but unless you put it out there, I guess people don't think about it, so just kind of see if you could give me some insight on that.
Through you, Chair. Julia
Please
Peak
feel free to go directly to the...
Thank you. I'll screw that up, I'm sure. So appreciate you. Julia Peak for the record. It's a great observation and really been challenging for public health for the last many years. For DPBH, when we integrated, we at the state were able to look much more closely about how behavioral health, mental health, and substance use combined is really affecting our population health, and we were able to work together more closely to look at interventions, population health-based interventions, where can we go upstream on behavioral health and substance use. Federally, there is still a bifurcation. Public health has traditional services, of which I mentioned, mental health, et cetera. However, I think Washoe County can speak to this as well. Within those foundational areas of public health, there's also opportunity for local-based focuses. And when we were on the call, the local health authorities and myself and said, like, what's that local-based focus that we add at the bottom? All of us said, like, behavioral health, no questions asked. So for us, behavioral health response is really integrated in those foundational public health services. Nationally, less so. They're just, you have SAMHSA versus CDC and HRSA, et cetera. So they can be more bifurcated, but I would say for us, over the last many years, we've integrated much more locally.
Thank you, Chair.
Thank you, Assemblywoman Gonzalez.
Thank you so much, Madam Chair. Oh, Cecilia Gonzalez, District 16 for the record. So as many of you know, I'm new to this committee, so I'm going to be asking a lot of like, what does this mean? What does that mean? And so I was just curious, number one, what do you mean when you say the decentralized public health system? And then number two, earlier in the slide, it said that, you know, only 2 states operate this way, Nevada and Texas. And so I'm just curious, like, why is that? What's the history? And do you see yourselves moving into a centralized system? Thank you.
Julia Peak for the record, great question, thank you. So many states are actually fully decentralized. So I would say a mature public health system is probably more decentralized than centralized, though several states are centralized, and it really just depends on how they've grown over the years. So a centralized system would be that the state health department offers all the services to the residents. There's not going to be a local health department structure. could be benefits and risks to that. Benefits, centralized funding, and so one entity would oversee the funding and the resources. Challenges, I would say, in that is that you don't necessarily have people locally making decisions for their own residents, and that has a number of inherent challenges. What we are moving to in Nevada is decentralized, so taking that largely away. So what decentralization would look like in Nevada is each resident has a local health department, a local public health agency that's overseeing the resources for them. And the state functions more in an oversight role and then also pooling money and getting it out to the locals. What's happening now is that the division pools in funds or has resources, and then we push that out to the local health departments where there are such entities. And then where there's not, in many of the rural counties, we provide that service. That means we have nurses out in the communities. It's challenging to fund that model. Sometimes you have a single person in a community offering the resources. So what I would say Nevada, to mature, what we would look at is fully decentralized. But as I mentioned earlier, that would take each county board of health dissolving, ideally choosing to regionalize in a district, but they could do it locally. But it would take that local authority and remove it from the state.
Thank you so much.
Thank you. So when you say fully decentralized, you did compare, well, maybe not make the comparison, but state that Nevada and Texas are the only one with our current model. Is the fully decentralized the model of the rest of the 48 states, and we are largely decentralized, which is what makes us the back burner actor?
Yeah, Julia Peak for the record, great question. And I did have a map illustration in here, but I know there's challenges with posting that. But I'm happy to provide that map so you could see it. What you would see is that the majority of Western states are fully decentralized. Where you start seeing full centralization is to the other side of the nation, but our surrounding counties are going to be primarily decentralized, or states, I should say.
Thank you for clarifying that. It reminds me of some of the challenges our school districts have with providing a nurse for the schools that can be on opposite sides of the county, and those counties where you don't have a centralized population. And it is one of our struggles in the West with just how much space we have to cover as individuals. Are there any other questions from the committee? Assemblywoman Taylor.
Thank you, Chair. And thank you for the report. It's very nice to get all the information. And I know you've been involved in so much stuff, and your name was all over everywhere, so it's really good to have you before us. I have a couple of questions, probably more of a follow-up. I want to make sure I understand. I see that the recommendation is to go fully decentralized, but I think I'm a little lost in the difference with the departments and the health districts. And I'm from Washoe County, and then we have a health district in Washoe County. So can you use that maybe as an example so I can get the picture?
You know what? Before we jump in real quick, I just want to say we have the health districts prepped and ready to present themselves. So they will give us a little bit of insight onto what they do. But if you want to give a brief 101 on what they do, that'd be great.
I'm sorry, if I may follow up, Chair. I just meant from a structure standpoint, not necessarily from what they do, but with the departments and the divisions, if that's okay?
Yeah, absolutely.
Okay, thank you, Chair. Please.
Perfect. Yeah, Julia Peak for the record. Cliff Notes version. So NRS 439 kind of spells out the differences between these, but one of the many things that are affected is the way they're able to bring in income and revenue to support themselves. And so they can speak about it as well, but they can pull in funding from their county budgets to help support services locally versus paying us to provide a service. That's a difference. So structurally, how are they different? So they're required to have county boards of health unless they choose to work with other municipalities or counties to become a district. And there's a number of reasons why you would want to become a district, which I'll let them speak to. But City of Reno, City of Sparks, Washoe County could come together and say, we think it makes sense not to provide bifurcation of services for the residents in this geographic area. Let's have a health district. City of Las Vegas, Clark County, et cetera. The ones in Clark, they've decided the same thing. Our first rural regional health district is actually the larger counties choosing to come together under one regional health authority. So what full decentralization would look like is, let's say, Northeastern Nevada, 3 or 4 counties choose to come together and dissolve their county boards of health and become one health authority. When we funneled money, we would not keep that money for our nurses. For example, we would push money to them and they would oversee what the nurses do locally. So it's a revenue and expenditure issue, it's an authority issue, and there's a number of reasons why folks have chosen not to do it and to do it. And the Central Nevada Health District might be best to talk to why they did it, because they're most new.
Thank you, Chair. That helps me so much. Thank you. Thank you, Chair.
Yeah, absolutely. It is a layered and complicated area. Well, we have a follow-up question on mental health, and I have to admit that I also was not super satisfied with the response about how you integrate mental health care into your foundational core areas. But Assemblywoman Newby, please go ahead.
Thank you, Madam Chairwoman. Hello. Good to see you, and thank you for your presentation. My question, the division obviously includes behavioral health, and looking at the org chart, which is not really a chart, it's a listing, of DPBH. It looks like there's also like NAMS and SNAMS and the Bureau of Child, Family, Community Wellness. Is that under as sort of a different division of the division? I guess it's sort of an organizational, because I'm very interested in mental and behavioral health, and so I'm wondering if we're going to have a separate presentation about that because it's a separate division under the department. Thank you, Madam Chairwoman.
Yeah, Julia Peak for the record. So we're under the same division within the Department of Health and Human Services. They're under different deputies. I oversee Child, Family, and Community Wellness, which has many of the traditional public health services, but I believe your presentation is this week for behavioral health as well. So my colleague, Cody Finney, is going to come present on substance use prevention, clinical services, and those kind of services. It's just a different presentation, but still within the same division.
Does that satisfy your question, Assemblywoman? Yes. All right. Oh, mine still feels like a little outstanding. So as I read through your foundational areas, and I'm looking at this slide 5 here, can you give us a little bit of a better idea of what I believe I heard you say, which was that mental health is integrated into each of these? Can you give us maybe some examples or help us spell out a little bit how that works with these particular foundational areas?
Sure, Julia Peak for the record. So these are foundational areas set by federal partners. So what we're trying to do is ensure that through public health accreditation, we're meeting these foundational areas. What we have the latitude to do is say what in Nevada should also be added to this list, and where are we going to devote resources, efforts, and based on all our community health needs assessment, behavioral health always is at the top. They're going to talk about maternal and child health, but typically behavioral health is at the top. So this illustration or slide just provides what the federal foundational public health services are. I'll say non-negotiable. So in order to meet accreditation, we have to prove that we're offering all these services under these capabilities. What we do locally is say what additional outside of this must we be doing to meet the needs of our residents. And could probably defer to Kevin during his presentation to touch on this too, because they are looking at behavioral health as a separate and unique intervention and resource allocation for that topic, because it's in our community health needs assessment that remains on the top of the list.
Thank you so much. I know most of us hear from constituents that is one of their top health priorities, and regularly have issues with either finding services or falling through the cracks. And so I knew you were doing work, but thank you for clarifying that this slide in particular is just those federals, and we have them spelled out elsewhere for the state's priorities and goals. All right. I think are there any other questions for Ms. Peak? Okay, we're going to go ahead and move on to the next presentation. I'm going to let you go ahead because I have, let's see. I have Southern Nevada Health District up next on my list if Mr. Legan, Dr. Legan is ready to present. But I'm not attached to how you guys present.
Hi, this
Hi,
is
Doctor.
Dr. Fermin Legan, Southern Nevada Health District. Let me see if Is it there? Are my slides there?
We're not seeing it. Well, let's see. BPS is jumping in to see if they can get it up for us.
Okay, just a moment. Let me try again. Just a moment.
Doctor, if you could open it up into the application and then click the share screen and open it up in presentation mode.
What about now?
We are
Perfect, thank you.
We are seeing it now.
Okay,
Thank you so
thank you.
much, BPS. Appreciate you. Please go ahead when you're ready.
Well, again, this is Dr. Fermin again, District Health Officer, Southern Nevada Health District. This is our organizational chart. We have a board of health that has 11 members, and they represent the county and the 5 jurisdictions here in Southern Nevada, including City of Las Vegas, City of North Las Vegas, Mesquite, Henderson, and Boulder City. We have different program areas, as you can see, and we deliver most of the traditional public health services that Julia mentioned before to our community. And also, of course, we have to take care of the millions of visitors that we receive every year here in Las Vegas. In addition to those traditional services, there are some other things that we do that are not common among most health departments. For example, 3 years ago, we received an award from HRSA to operate a federal qualified health center. That health center is actually delivering services from 2 different facilities here in Southern Nevada, and of course, so helping with access to care, especially providing primary care services. Also, our team is delivering the syringe exchange program through vending machines. Those are offered at different locations here in Clark County, and also have been offered in rural areas. We also have our public health lab here, which provides services to all Southern Nevada. And also our organization has a management trauma system that collaborate with hospitals and EMS services here in Southern Nevada, and help with all the designation of trauma levels in collaboration with the state. And also we have provide mobile health services across the community here in Southern Nevada, and also occasionally at other rural areas neighboring Southern Nevada. In terms of recent success for our organization, last year we received the public health accreditation, and this was the result of more than four or 5 years trying to get that. Finally, we received that award last year, and we joined our peers in Washoe and Carson City. Also, in collaboration with UNLV and multiple community partners, we completed our community health assessment, and then we follow up with the community health improvement plan that is already in the phase of implementation. Something that we feel very proud is that last year we were able to create a congenital syphilis management program. And this is a very important program because unfortunately, Southern Nevada is one of the regions in the country with the highest levels of syphilis. And also, unfortunately, we have multiple mothers who do not receive early prenatal care and are diagnosed with syphilis at the end of their pregnancy. Unfortunately, we have so many cases of congenital syphilis. So we already have a team working with that we want to expand. We opened a new health center facility as part of our federal qualified health center in Fremont Street, which is an area of need here in Las Vegas. In addition, also, we open another facility, a smaller scale facility in East Las Vegas in collaboration with the city of Las Vegas. And also our IT team and our environmental health and the food handle team, they, in response to the high demand for food handle cars that we had last year, they created an online system that help us completely eliminate the long waiting list of people for this service. We have also, of course, our vaping prevention program. More than 7,000 adolescents received that training from our team. Also, the community, not just Southern Nevada Health District, but also our community partners administer more than 780,000 COVID vaccines this year. In terms of challenges that we have for this year and the near future, the implementation of the community health improvement plan that we mentioned before, also the implementation of the public health infrastructure project, and this is a grant that we received from the CDC. It's a 5 years grant that the initial year, actually last December, they allocated $22 million supporting this effort. Also, we are working with our local jurisdiction here to expand our public health lab. Our goal is to have $10 million to invest in that expansion. So far, and until today, we have reached a total of about $6.4 million for that purpose. And in addition to that, of course, one of the biggest challenges that we have, and I believe that it was mentioned before, is also advocating for approval in Nevada of sustainable public health funding, which is a big issue here across Nevada. Unfortunately, Nevada is in the bottom of public health funding in the country. Right now, also, we are in the process of building a behavioral health center at our main facility in the Cattle Boulevard, and that's part of the effort from our Federal Qualified Health Center to expand behavioral health services here in Clark County, in collaboration, of course, with other community partners that we have here. We are also planning to build a dental health center at the Fremont Street facility to offer those services to children and adults across the community. And of course, our team is engaged on continued effort for fighting the tobacco and vaping epidemic, as well as the opioid epidemic and the syphilis, HIV, and sexually transmitted diseases epidemic. Because again, Southern Nevada is one of the regions in the country with the highest level of syphilis and other sexually transmitted diseases. I believe this is my last slide.
Thank you,
So you have
Dr.
any questions?
I appreciate it. Are there any Again, thank you. Are there any questions from the committee? I have one, please, Assemblyman Gray.
Good afternoon, Doctor. On your slides, I'm trying to find it here real quick. Under successes, you've got two things there that I'd like to know a little bit more about. The youth trained by the vaping prevention program. Has anybody done a follow-up on that to see how many of those kids have started vaping? I mean, what the true success was? And also, what is a COVID-19 vending machine project?
Okay.
Not something I want to buy from a
well,
vending machine.
Sure, absolutely. No, I don't, regarding the vaping prevention program, I don't have that data with me right now, but I can certainly ask that data from our team and forward that to you. So that we can do. I don't have that in front of me right now.
Dr. Legan,
And
if you could forward that to staff, then they would send it to the rest of
yes,
the committee as well. Thank
absolutely.
you.
Sure, absolutely. Thank you. And the other question was, I forgot. The second question?
What's the COVID-19 vending machine program?
Oh, okay. Well, this is actually making COVID testing more accessible to the community. So this is actually the home kits that the federal government was offering several months ago, and we got those machines and we place them at different areas here, like for example at our Decatur building here in Las Vegas, also at Fremont Street, and also there is another that with the regional transportation system at one of the stations here. And also we have another machine in Mesquite, and I believe in Lawfield as well.
Thank you for the question.
And those are free. Yes.
Great. I am looking at your goals and challenges, and I was going right before you got to the slide. I wrote down, ask what the 3 top challenges are for your health district. Could you go over this? Because there are several and kind of layered goals and challenges listed on your slides, but could you go over maybe 3 of like the top priorities from your office that you're maybe putting resources to advance forward over this next biennium?
Sure. Thank you. Well, I would say expanding our capacity of our public health lab is one of our main priorities, and that's why we are requesting for assistance from the local jurisdictions, and we are receiving their assistance to help us with that. Also, the public health infrastructure project, which is a grant from the CDC, and it's very important because that will help us sustain the effort that we're doing now for COVID, and also to retain employees. One of the biggest challenges that we have here in Southern Nevada is actually retaining talent. So this grant help us with that. And then again, also the implementation of the community health improvement plan is very important, because this is the result of the community health assessment that, in partnership with multiple community partners, help us identify areas that we need to enhance our work. And I will mention as well the effort that we are already doing, and we want to expand into in behavioral health. As I mentioned before, that's one of the reasons we are creating this behavioral health center at our main facility. We want to expand our workforce dedicated specifically to behavioral health here in Clark County.
Thank you so much. I look forward to seeing how you integrate those behavioral health care workers into that facility, and what that model ends up looking like. I have a couple more questions from our committee members. Assemblywoman Newby, please go ahead.
Thank you, Madam Chairwoman. Hello, Dr. Legan. I have a question on your slide 6 under your public health laboratory expansion, the $10 million investment. It lists the BSL-3 and molecular and microbiology laboratories. Is that the same project as the one that was funded with the ARPA funds, or is that separate from the state
No,
effort?
that's separate. That's separate, actually. The one with the ARPA fund is, I would say, mostly dedicated to academics and also some public health component, I would say. But that's a different one, and that's not our lab.
Thank you, Madam Chairwoman.
Thank you. That was a great question. I, I know that we've lost some laboratories down in southern Nevada in the environmental world, so I'm grateful to see the standing up of a couple more laboratories, although they don't cross over all the time into the same space. But I have a question from Assemblywoman Taylor. Please go ahead.
No, I'm good. She took care of it already, Chair. Thank you.
Oh, great. Okay. Are there any other questions from the committee? Yep, Assemblywoman Gonzalez, please go ahead.
Cecilia Gonzalez, Assembly District 16 for the record. Thank you, Madam Chair. So I was curious what the district is doing to outreach youth in regards of sexually transmitted diseases. Thank you.
Okay, thank you. Well, that's part of the program that we are doing in general with health equities. We used to have, I would say, a program that was specifically directed to the youth, and that was a youth pregnancy prevention program. Unfortunately, that was a federal grant, and as you may know, federal grants come across and they also disappear. We last year we lost, or 2 years ago, we lost the funding for that grant. There was some reorganization on that program. So what we have now is with our health equity team and also other components of our community health division addressing the youth through different interventions. But we don't have today a program specifically directed to addressing all youth programs here in Southern Nevada. That's one of the areas that certainly we need to enhance. But again, we lost the funding for that purpose 2 years ago.
Thank you so much.
I have a follow-up on that one. Is there a action plan in place to try and regain that funding? And could you please state your name for the record when you speak? Thank you.
Thank you, sir. Fermin Legan, District Health Officer, Southern Nevada Health District. Again, the only way that we can do or incorporate new programs is by having additional funding. It depends on opportunities from funding, whether it is from the federal government or the state decide to allocate funding to address specific issues. That's when we can actually create or expand programs. We receive a certain funding from Clark County, from the property taxes. That's usually that's about somewhere between 26 and 29% of our funding. Most of our funding is federal today, and also another piece of that is coming from the services that we deliver. But for us to create new programs, first we need to have funding. Unfortunately, the funding we have is very limited, other than the federal grants that we receive, and again, the limited funding from the property taxes.
Thank you for that response. Are there any other questions from the committee? Well, thank you so much, Dr. Ligon. I appreciate you being here today. And folks, if questions do come up, now you have a face to reach out to with questions as they arise. All right. Next presentation I have on my list is Washoe County Health District. I have District Health Officer Kevin Dick at the table. Please proceed when you're ready.
Yes, thank you, Chair Peters, and it's a pleasure to be with you and the committee this afternoon. I'm Kevin Dick, District Health Officer for the Washoe County Health District. And if you go to the next slide. Our District Board of Health is composed of 2 members from each of the jurisdictions that form our district. So we have 1 appointed and 1 elected member from the city of Sparks, the city of Reno, and from Washoe County. And those 6 members of our board appoint a physician to the board. The Health District was established in 1972. We've actually provided services for the county since the 50s, but there weren't a lot of things written down early on in that history, and we were formalized in 1972 to form the Health District under the NRS structure. And we have about 192 FTEs. That's when we're fully staffed at the Health District, which doesn't seem to ever occur. There was a question about how we and the state differ with the districts and the department. I would just note that for most of the federal funding opportunities, but not all of them, there's a requirement for eligibility to apply for those funds that you be a state or you be a county with 2 million or more population, or have a city of 400 or more thousand population. So Clark County, Southern Nevada Health District, is eligible to apply directly for a lot of those funds. For Washoe County, we don't meet those eligibility requirements, and so in order to access those funds, we have to work with the state to be included with their grant funding and be able to have a sub-grant from the state to be able to access those funds. I'm going to run through slides of our direct service divisions that we have within the health district. I won't be able to cover in depth or even touch on each of the different areas that we work in because it's very broad with public health, but I wanted to give you a flavor of that. And I'd also like to mention, I think during the COVID pandemic, we all experienced the chaos that resulted from that public health emergency with the lockdowns occurring, essential businesses being the only ones open, the uncertainty that all of us faced as to whether we were going to have to be isolated or quarantined, whether that was going to impact our children in their classrooms, just massive disruptions. And I want you to consider that if we didn't do all of these programs day in and day out in public health, that would be our life every day with that kind of chaos going on without public health protections that we have in place. We're unique in Washoe County because we have an air quality management division. So we're the only health authority in Nevada that has that responsibility, and we implement the Clean Air Act, federally Clean Air Act for Washoe County. We're impacted by wildfires here in northern Nevada, and so one of the important functions that we have is our network of monitoring stations and reporting to the community on air quality and when it's unhealthy and what they should be doing in order to protect themselves. We also are right on the borderline for ozone and being out of attainment with a federal standard. So the precursors for ozone come from motor vehicles as a primary source. So the smog control program and smog checks are very important to us, as is regional planning to reduce vehicle miles traveled and electrification of our fleets. Next slide. We have a community and clinical health services division, which provides a number of different services that you see on the slide. The picture that we have there is from the testing and vaccination drive-through operation that we were running through the earlier in the pandemic. And we administered over 218,000 vaccinations for our community. We have, for our immunization program, childhood vaccinations as a focus area, ensuring that our children receive the vaccines that are required for them to attend school. And we're now planning for our back-to-school vaccination clinics that we offer. We partner with the school district to conduct those. We have a WIC program, Women, Infant, and Children, that provides supplemental nutritional assistance to help keep our kids growing up healthy. And we also work with the schools on smoking and vape prevention programs. I wanted to touch on family planning and sexual health. We inexplicably lost our funding along with Department of Health and Human Services and Carson City Health and Human Services for under the federal Title X program, which is for family planning services. And this occurred in a moment of time. We've been receiving this funding for over 50 years. And so it wasn't explained why we didn't receive our funding. All of our proposals were approved. But we were fortunate to be in a snapshot of time where ARPA funding was available. And Ms. Peak worked to help us with the Interim Finance Committee to get ARPA funding for us to be able to continue to provide those services through December of '26. That was a 5-year grant from the federal government that we didn't receive funding for. So we're able to continue those services because of that ARPA funding infusion. But it's an example of the importance of providing flexible funding for public health, and the Public Health Improvement Fund, which we've been advocating for a number of years, would have been a potential source of funding to be able to continue providing those very important services for our community. Our epidemiology and public health preparedness program is on the epi side focused on preventing and addressing outbreaks. And again, we work very closely with the schools and our educational system to help them keep the schools open, to prevent outbreaks from occurring, and when they do, to address those outbreaks and prevent further spread in the community. So a number of our programs are focused on how do we keep our children healthy so that they can learn in our educational system when they show up at school. And I think everybody understands now the importance of preparedness planning as far as planning for public health emergencies, as well as working with our regional partners when we have natural disasters that we need to respond to. Slide. And then we also have an environmental health services division, and this covers a number of areas looking at how do we help keep our water clean and our food safe and general sanitation issues for us. The slide in this picture is a helicopter that's part of our aerial larvicide treatment program that we do for mosquito abatement to help prevent the spread of West Nile virus and viral encephalitis in our community. I have a sign in front of me that says define acronyms. So the UST that's on this slide is underground storage tanks, one of the things that we permit and regulate. I wanted to touch on our food safety program, which is a major program that we have and nationally recognized for Washoe County. And this is very important for our economy with the number of restaurants that we have associated with tourism and with special events that we have in our community. And just as an example for you, we have the annual Best in the West rib cook-off that occurs around every Labor Day in our community. And we have cookers from all over the country that come, and it's a huge event. We spend significant effort in working with that event to ensure the food safety. And some years, we have to work with vendors to dispose of thousands of pounds of meat because they haven't handled it properly and kept it in the temperature controls that are required for public health and food safety. And so this is part of the work that we do that nobody sees. But imagine if we had a major foodborne outbreak that occurred at the rib cook-off. It could really have huge impacts economically for the Washoe County community. This is an overview of my office of the district health officer, and the work that we do, we're a nationally accredited health district, received that accreditation in 2019. And I think that work that we did to have the systems in place and the management structures, the planning structures, the performance and accountability structures really served us well through our pandemic response. But a lot of this work is ongoing work that we now have to maintain that. And one of the items I have on here is our community health assessment and improvement plans. Behavioral health has come up a few times, and there have been questions that are asked about that. Behavioral health has been a top priority that's been identified in our community health assessments and work in our community health improvement planning. And in Washoe County, we see the role of the health district as helping to ensure that our community has access to behavioral health services that they need. Not that we necessarily be the direct provider of those services. And we've been working over the past couple of years with our cities and the county, our healthcare providers, both providers and payers, to facilitate a discussion and implementation planning around how do we provide crisis response services in our community. And so we're in, I think, the final phases of that, with one of our hospital systems negotiating with the state on a property to be able to provide a 24/7 crisis response center in our community, and also supporting the planning around that entire crisis response system of how do we connect the 988 crisis care line with people that can respond, mobile response units to respond to those crises, or to be able to navigate people to the crisis response center if they're not able to be de-escalated during that phone call. The other, I think, really significant area for us that we're working on is health equity, and we all saw the disparate impacts of COVID-19 and how, particularly when we were most vulnerable early on in the pandemic, those impacts occurred on our essential workers, the workforce that couldn't work remotely, had to show up for work, many times had to because they had to keep a roof over their family's head. They needed that income. Oftentimes these were workers in our minority communities, oftentimes without any paid sick leave, living with intergenerational, multi-generational families in tight quarters. And so we really saw those impacts occur through COVID-19. But we also recognize that those social determinants of health are drivers for either good or bad health outcomes for people in our community, and probably much more significant than the health care that they receive is the zip code that they live in and grow up in. And so we've made a significant investment in health equity with some grant funding we were able to receive, and are able to keep some of that staff going with some continuation grant funding, but really working, and we now have a health equity organizational capacity plan that we're implementing. We've got some community organizers that we have on board to try to better engage with different parts of our community. We found that was lacking when we needed it during COVID-19, and some community health workers to work in our clinic services and help outreach to our community. And then I think workforce, I'm going to touch on it in a moment, is very important for us, and our communications program. We're working to further beef up our communications. I think we did a pretty good job communicating through COVID-19, but there's more and more misinformation and disinformation out there that's so important for public health to be engaged in getting the right and science-based information out for our communities. And then I think this is my last slide. I was mentioned a few times by Ms. Peak to talk about some of the work that we're doing around our workforce capacity. And so you heard about the fundamental public health services from Ms. Peak's presentation, And I'm a little ahead of what Ms. Komlasi is going to talk about in her presentation coming up, but there's been a lot of work that's been done nationally on staffing and what the right staffing levels are for public health. And we had been operating in a cost control model for a number of years prior to COVID-19, and that really bit us when the pandemic came along. And it's important that we do make an investment in public health. So we have been working with the National Public Health Foundation, who we brought on to work with us to beta test a new public health workforce calculator that's been developed by the University of Minnesota. And this calculator was developed based on work that's been done in a number of states now on assessing what is the workforce that public health should have to be able to provide those foundational capabilities. That being the foundation, what you need to have a strong health department to be effective and to be able to support the additional community programs that you develop based on needs in that community. And the calculator is set up to be able to help identify by the size of your population that you serve, how many staff you should have for those foundational capabilities. And so we went through each position that we had at the health district, and we identified FTEs that were providing those different foundational public health capabilities and services in our health district. And what we found, just as running raw numbers through the calculator, was we needed about 50 additional FTEs for a community our size to fill the gap. Then we did the second phase of that exercise, which was looking at who are the partners in the community that may be providing some of those services. So Ms. Peak had that slide which she talked about other public health partners, and we assessed, okay, what proportion of these services are being provided by these different partners and how important are they for our community? And from going through that, we ended up with 24 additional FTEs that we needed to fill the gap for foundational public health services. And then we're currently working on what is the staffing we really need to do a good job in providing the additional community-specific programs that we have. And just a brief example, the immunizations, for instance, is a foundational public health service area. So educating the community about immunizations and promoting them, ensuring that the providers, the pharmacies and the doctors are handling the vaccine properly, keeping it refrigerated, et cetera, and are administering it properly, that's the foundational area. Actually putting shots in arms is not foundational. That's a community need that we're addressing through the health district. So there's what we call below the base, and that's what this 24 additional FTEs are for foundational services. But there's also additional workforce that's needed for those community needs that we address through our programs. So I think I went a little bit long, but please excuse me. I'm happy to take any questions.
Fitting all this into 5-minute requests is not an easy task, so I commend you for attempting at least. We have a few questions, I think, and please correct me if I'm wrong. I have running lists here, but Assemblywoman Newby, did you have a question? All right, this is my old list. Sorry about that. So we've been talking about mental health, and you went over the crisis model that you guys are developing out. I do understand that we're going to be hearing from the regional behavioral health policy boards and later this week, I think. But can you give us a little bit more detail on how that fits into, like, the public-facing model, right? How do you let people know that these services exist? How do you connect people with community-based services? How do you become that provider of like the hub of services that our community needs?
So the health district does referrals through our clinical programs with people that are coming to us that way. We also work with the 911 system, and EMS. So I think Southern Nevada also has EMS under their health district. In our health district, we don't do licensing, but we work with how that whole system works together. And so we're in the mix with regionalization discussions that are currently going on about how to improve that structure in Washoe County. But there's a lot of behavioral health services that end up falling into EMS and law enforcement because of the lack of a system and providers that we have out there. This crisis response center that I was talking about is meant to be a place where people can be taken instead of going to jail or an emergency room, because there's no other place to take them. But our goal is to work on the system and have that 988 line be well recognized by the community for them, people that are experiencing crisis, to be able to contact that number and either get the de-escalation that they need there, or have a warm handoff and care from the other components of that system. But we really need more behavioral health care providers ultimately, and our regional Behavioral Health Policy Board is the bill BDR that they're bringing is to help with loan reimbursement and for faculty for providing us with educated behavioral health providers for our community. There's a lot of work that needs to be done in this area. I think that Washoe County, not the health district directly, but Washoe County sees a role for the county in how to be providing those services. And for instance, with people that do end up going to the jail, how can we provide through the county outpatient services for them that will help them reduce recidivism and going back to jail, so they're getting the care that they need. So we've had discussions at the local level, and we don't feel that it's appropriate for the health district in Washoe County to be providing those services directly, but for the health district to play the role that we are, which is how do we facilitate those discussions and the planning and the decision making that helps us to get those services for people in our community. And I think on the part of the county, there's an interest in how could they be more engaged with how the state behavioral health dollars are spent, and how could they help guide the decision making for how those investments are made in the community.
Thank you for that response. It is really an issue area of how do we ensure we have enough providers, and layered into your agency and the folks you need, the 25 or so FTEs that you need, in addition to how we're going to stand up a crisis response center with the FTEs and bodies needed to respond or to staff that facility, and other community-based facilities that may blossom out of this model that allow for maybe a little bit less of a triage service and more of a preemptive service. There's a lot of focus right now on building that pipeline, that workforce pipeline, and we're just in the unfortunate position of it just there not being enough folks around to provide these services. I had one other follow-up on something you mentioned briefly in your presentation, your health equity plan. Could you provide the committee with a copy of that, please? Awesome.
Be happy to.
Thank you so much. And does anybody else have any questions for Washoe County? All right. Well, thank you so much again for being here today. We really appreciate it. And as with the previous presenter, you now have a face to the name. If you have questions, you can reach out either through staff or directly to Mr. Dick. Appreciate you being here. All right, next on my list, I have Nikki Aker, the director of the Carson City Health and Human Services. Please go ahead.
Good afternoon, Nikki Aker, Director, Carson City Health and Human Services. And thank you, Chairwoman Peters and the committee for inviting us to give you a glimpse of what public health looks like in Nevada. So as I stated, I am the Director of Carson City Health and Human Services. I am not the health officer. And we are not a district, but we are a health authority. And I'm going to give you that glimpse of a different model that is not a district. So like I said, we have a county health officer, and that is outlined in NRS. And then also within our own municipal code, it requires a license to practice medicine in Nevada and maybe a Carson City physician. So it's a little bit more prescriptive. When the Carson City formed their Board of Health, we're a consolidated municipality, so we're a city-county, and they chose to go with the county health authority requirements. And so our Board of Health composition is our county health officer, who is chair, and she's our county health officer, Dr. Colleen Lyons, and it is done by a contract. And we have our Carson City Board of Supervisors, of which there are 4, our sheriff, and the county clerk, who's the clerk of the board. So we are a department of the city, and we, as being a local health authority, we don't pay assessments to the state because we provide our own services. The FTEs right now, I've got 44.1 FTEs, and that is 63 employees. And I right now have 7 positions that are very hard to hire, and more coming on board that are going to be difficult to hire as well. We achieved public health accreditation in 2016. And like Julia Peak presented, it's about measuring up against those national standards. And that's a very important piece of that. And we have put in our documentation for reaccreditation and waiting for a site visit on that. And the reaccreditation takes place every 5 years. So I'm going to give you just a glimpse of our different divisions, what happens within them. I do have the 6 divisions with fiscal support as well. I've got our chronic disease prevention and health promotion division. Within that division, I have 3 programs. I have the tobacco prevention and control program, the Adolescent Health Program, and the Ryan White Retention and Care Program. And as you can see, those are very limited of what I've got in chronic disease, and there could be many other things that we could focus on, but we are limited with the grant funding of what we can do. Our adolescent health program does go into schools and detention centers and provides sexual health education, and that is where we also provide information about sexually transmitted infections and how to protect themselves and how to have healthy relationships. Our Ryan White Retention and Care Program, this is about getting individuals that are HIV positive back into care. They have fallen out of care, and it's getting those individuals back into care. And we've talked a lot about behavioral health here, and that is a program that deals with a lot of behavioral health issues and connecting individuals to providers or finding solutions for them, because there's a lot of times a lot of barriers of why individuals have fallen out of care. Our tobacco prevention and control, I just want to highlight a success that they had. They were working with an apartment complex here in Carson City, and it's a pretty large complex, and they got that complex to adopt smoke-free policies. So they worked very hard on that. Within clinical services, as Mr. Dick indicated, we were approved, our application was approved for Title X or family planning, but unfunded. So we are very grateful to the state that they have come through with some funding so we can still provide those services. We do have a lot of teens that we see within that program. And again, as Mr. Dick indicated, within that program, there's screening for behavioral health. And so, and if something is an alert, then we can connect that person to someone that can help them. We have environmental health, and we do environmental health in Douglas County through an interlocal agreement. So, and I'm going to tell you just different things that we do within the county, outside the county, and it's all a mixture of things. So, but as you're probably really familiar with, environmental health is those restaurant inspections. And I'm going to back up just a minute, our chronic disease prevention and health promotion division, we do all of these services outside of our county as well as Carson City. We work with partners in Douglas, Lyon, and Story County, and Ryan White does 15 other counties. They do the rural and frontier, and when we take our next grant is going to be statewide in that program. So moving on, we've got epidemiology, and we do disease surveillance or investigations in Douglas and Lyon County. And we do this as a delegation of authority from the state and grant funding. This was a division that actually, because of COVID, we were able to divide environmental health and epidemiology into two divisions. Prior to the pandemic, they were combined. It was recognized that just was not feasible during COVID and during a time of a pandemic. The workload was way too much for one division. During the pandemic, this division, there were more than 11,316 cases that were traced, and many of those received individual interviews. So when I mean traced, it could be you have your case, and that can lead into many different interviews that needs to happen with individuals. We have at Carson City Human Services. And a lot of times you don't see human services within a health department. It works really well for us. And that allows us also to work within that behavioral health realm, not giving direct services, but connecting people with services and working within that behavioral health system within Carson City. And the human services, it still provides Carson City's mandated services that we do only for Carson City. And we have a WIC program within Human Services, and we provide that service within Carson City and Douglas County. During the pandemic, the Human Services was instrumental in assisting with services within Carson City, such as delivering groceries, picking up medications, and much more. And we were also able to connect with the other human services in the other counties, and they assisted their citizens as well. Talking about behavioral health, we do facilitate the Carson City Behavioral Health Task Force, and that's done within the Human Services Division. And it's bringing community partners together to discuss what behavioral health issues we have in the community. And one thing we have recognized is it's just not a Carson City issue for us, it's a regional issue into the other counties. So we've started having those discussions with the counties surrounding us of how do we look at this regionally. We work very closely with the mobile outreach safety team that is in the sheriff's office. And those individuals go out and they assist people that are having a crisis. We were able to put 2 teams out, which is very helpful. Our teams consist of a clinical social worker and a sheriff deputy that specializes in behavioral health issues. Then we also have our Public Health Preparedness Division. With that, we have delegation of authority through the state and grant funding. You may have heard of the Quad Counties during the pandemic. That is us, and mainly public health preparedness. I just want to highlight during the pandemic that we conducted 307 mobile points of distribution or dispensing. It sometimes is both ways, or you'll hear me call it a pod. And I want to emphasize mobile because we went into different counties, into different communities. I like to say that we took our show on the road. And we administered just with these our pods, we conducted we administered 77,588 vaccinations, and that's across the 4 counties. And then also during the pandemic, we stood up a call center within the department, and we received more than 40,390 calls. And now in October, we were doing our flu vaccination events. So we went from doing COVID to flu, and then last year we're doing COVID and flu. We conducted 58 flu vaccination events in 6 weeks throughout the Quad County region. Again, those being mobile, so taking our show on the road. And I just want to take a minute and discuss the community health needs assessment. It's been brought up a couple times about that assessment, and that is very crucial to public health accreditation. We, this time, were able to partner with Carson Tahoe Hospital. We did do it as a Quad County region because they also see individuals from those other counties. And that was our 3rd assessment. You can see the priorities that have risen to the top there. And as you can see, mental health, substance use, not surprising. And you may be asking, why is this assessment important? Well, you need to look at what does your region or your community have as far as health services, public health services, and determine what those needs and gaps are. And that's what you want to work on. And so the next steps for us is going to be working on that community health improvement plan with our partners and residents. And I say residents, we want our residents involved. And that will be for the 4 counties. So that concludes my presentation. Happy to answer any questions.
Thank you for the presentation. We have a couple questions. I'm going to go ahead with Assemblywoman Gonzalez first.
Thank you, Madam Chair. Cecilia Gonzalez, District 16 for the record. On your slide under your overview, recruiting for 7 positions, which you stated was really difficult, I was curious, what are the challenges to hiring these 7 positions? Thank you.
Thank you for that question, Nikki Aker, for the record. Some of it's the actual positions. Like we have a public health nurse that we have had posted for a very long time. Initially that we wanted a bilingual nurse, and that's for the clinic. We recently have had to drop bilingual and we'll be happy with a public health nurse. So we've had a very difficult time with that one. We've had some part-time positions that have been very difficult to recruit for. And this day and age, people are looking for those remote jobs. And we're not an agency that can work remote. We need to be in the office, and we need to be able to work with our clients on a face-to-face basis.
Yeah, follow-up, Chair. So in terms of dropping bilingual, has that made it easier to hire someone? And then when you get bilingual folks, how do you go about servicing those folks? Thank you.
So we just dropped that requirement, and still do not have applications that we're reviewing at this point. So no, it has not helped us. But we do have bilingual staff that can communicate with our community, and we also have a translation service. So, and the translation service does a wide variety of languages, so we can provide those services for whoever needs them.
Thank you so much.
Thank you for the question. Assemblywoman Taylor, I have you next.
Thank you, Chair. And thank you for the presentation. Thank you for your work. Just a question on the immunizations. It looks as though for the Quad counties, you did quite a bit of them. I'm wondering if you have any kind of a partnership or relationship with the school districts in any of those counties for those required immunizations for school children?
Yes. Yes, we do have a very good relationship with the school districts, and here in Carson City, and we went into the schools, not with COVID shots. We didn't want to take those into the schools for the kids, but we do it on the flu shots. So even through COVID, we worked very closely with the schools and did some of the events even at the schools.
May I follow up, Chair? Thank you. Oh, that's great to hear. So on those, other than flu, do you do anything that maybe that would provide those vaccinations that are required for school attendance, or you really just target the flu?
Oh, no, within our clinic, we do a variety of immunizations. Those required for school, adult immunizations, pneumonia, shingles, so we do a wide variety. We have a immunization day, which is Thursday. It's a walk-in clinic day, and people can come in and get their immunizations.
Okay, thank you very much. Thank you, Chair.
Thank you so much. Assemblywoman Thomas, I have you next.
Thank you, Madam Chair. Thank you for the presentation. I appreciate it. Good information that you're sharing with us. One question that I do have, actually it's more than one question. Substance use. Do you have the data that shows or would show the people that you are servicing, their drug problems? If they have drug problems, I'm assuming that they do. So I might be wrong. That I'm hearing and reading that in rural communities we have a higher, an untapped use of substance abuses. So I was just wondering if that's something that you have data that you're keeping track of.
So there.
Do you mind stating your name for the record?
Nikki Aker for the record. Caught myself there. As far as drug use, some of that can show up in our community health needs assessment. The program that we have at the health department is just tobacco, and then we've got some funding for vaping. So that's one of those areas, even if we really look at the data and look at the drug use within our community, I don't have funding to do anything about it. So that's where, we run into some issues with that categorical funding.
Follow-up, Chair, please. Thank you. So with that question, what about mental health? You're not assessing people that have mental health issues that are related to drug use?
So, Nikki Aker for the record. Where we look at that is in our human services and our clinic. And if one of our educators or one of staff are out working with an individual, they recognize that there may be some issues with drug use or something, then that is where we can connect them to somebody else within our community. We have those referrals in place, and we know those institutions that provide those services. And so we'll be that connector, if that helps you.
Follow up, Chair, please, for the record. Thank you. So the sheriff that sits on your board, excuse me, does he have an input? Because I'm sure that he receives probably people that have a substance abuse issue and or mental health. So is he giving you information on that?
Nikki Aker for the record. Our sheriff in Carson City is very involved with behavioral health, so the mental health piece of it, the substance abuse. And he also sits on our regional behavioral health policy board, of which I sit as well. So yes, he does give information to us. He also will do it through the Board of Health. And that is where he was very instrumental in wanting to have our community be serviced by 2 MOST teams, or the Mobile Outreach Safety Teams. Again, those are individuals that will go out to a crisis. They've got a clinical social worker and a deputy that specializes in behavioral health issues. And if the crisis is bad enough and they feel that the individual needs some very intense treatment, we also have the Mallory Center, which is that crisis care center, or your mental health emergency room per se. And so we do have the luxury of having that within our community. So, and the sheriff is a huge proponent for behavioral health in Carson.
All right, thank you. Thank you, Chair.
Thank you so much, and thank you for the responses. Are there any other questions? Yes, Assemblyman Gray, please go ahead.
Thank you, Madam Chair. Just a quick statement, actually. Nikki, good to see you. Thank you for everything you did as a former member of the Lyon County Board of Health. Didn't always agree, but you always did a fantastic job, and you and your team just performed wonderfully. Thank you.
Thank you for that.
Thank you. And yes, an extension of our appreciation to all of you. I do want to remind members that we try and use decorum in here to refer to folks with their last name and appropriate salutation. Thank you so much, Ms. Aker. I appreciate you being here today. The next presenter on my list is Mr. Caleb Cage. Please go ahead when you're ready.
Good afternoon, Madam Chair, members of the committee. My name is Caleb Cage. I'm the interim administrator of the Central Nevada Health District. I am proud to provide you an overview of our brand new health district here today. Throughout the presentations that you heard prior to this, you heard a lot of talk about the foundational public health services. You heard a lot about the challenges and opportunities in different districts and authorities and areas throughout the state, and the robust capabilities from organizations like the Southern Nevada Health District, the Washoe County Health District, and Carson City Health and Human Services. As you can see from my opening slide here, we are so new that our logo was approved after I submitted these slides. So we are aspirational of all of our partners and peers throughout the state. Established through NRS 439.369, which has been referenced a few times throughout this presentation. The Central Nevada Health District is made up of the 5 communities whose logos are across the bottom of this slide, and they are Eureka County, Churchill County, Mineral County, Pershing County, and the city of Fallon. Next slide, please. So again, you've heard a great deal about this, the lack of health districts in Nevada and Nevada's overall structure. There are 2 health districts that are formally formed here in the state, in Southern Nevada and in Washoe County, and the rest of the state either falls under a health authority structure or through under the Department of Division of Public and Behavioral Health. All of these communities throughout the state present challenges through diverse community needs, and we could pick any rural or more populated area in the state, and the needs would be different. The challenges would be different, and those are due to the geography, where they sit, how many people are in those communities, and what services are provided. The amount of funding that is based on population to support public health also presents a challenge, which is brought up many times. In fact, all of these have been brought up numerous times throughout, as well as the capacity in local communities to provide services. And of course, something all of us are facing in public health and in every industry here in the state of Nevada, the necessary workforce in order to provide those services. Next slide, please. So they're not just challenges, there are opportunities as well. A lot of these opportunities have been known for a long time throughout the state of Nevada, certainly throughout rural Nevada, but a lot of them came to bear through lessons learned from the COVID-19 pandemic. And that's really where we see the genesis of this Central Nevada Health District and its the relationships and the impetus to develop a public health district overseeing 4 rural counties and 1 rural city in order to coordinate the services, in order to serve the largest number of people, in order to maximize the use of available resources. Maximizing the use of everyone's resources comes through a number of ways, and I've listed a couple of them here. Improving the capacity of existing agencies to address a wider scope of public health problems, including communicable disease control, increasing community input, which we've heard time and time again throughout these presentations is a critical aspect of what public health districts do in our state, improving preparedness and providing additional resources through a district model or a regional district model. Next slide, please. So based on the challenges that were present and the opportunities that were available, especially as highlighted through the COVID-19 pandemic, leaders across these 4 counties, which are highlighted on your map here, sought to establish a single Central Nevada Health District as a solution to address Nevada's public health challenges as revealed by the pandemic. This is, it's been said a couple of times, I never want to miss an opportunity to say this, how historic this is, as the first rural public health district in the state and the first multi-county public health district in Nevada as well. I'm especially proud to be a small part of that, having not been around for the early days of this, but to see the work through since December to make sure that we are carrying out and on the promise of the opportunity of establishing a district. And this is done through leveraging current local capacities, increasing local investment. So although the assessment has been waived by the state, this actually costs more money for the jurisdictions that are involved in this to provide public health, and I think that's a great testament to their commitment to serving their populations here, and of course increasing partnership and collaboration with local partners as well as with the State Division of Public and Behavioral Health under DHHS. The goals of the Central Nevada Health District here are, again, we're in the very early days, but are to build sustainable resources through partnership. No one community in the state, it doesn't matter if it's public health or emergency management or any other area, has all of the resources it needs. So how does it work with private sector, nonprofit sector, and public sector partners in order to maximize those resources? How do we work to reduce the duplication in services? This is something we talk about a lot in public service to make sure that we are using the resources to their greatest and best benefit for the community. Engagement, we keep coming back to this because it is so important to make sure that in order to meet the community's needs, we're listening to the community, we're doing those health assessments, we're engaging with the public as much as possible. And of course, to remain flexible with such a large amount of land and population spread sparsely across it, as well as the different funding mechanisms that are available to us. We need to make sure that we are agile in our ability to provide these services to the local government. Next slide, please, or local communities, rather. I have a couple of timelines here. I'm already over time, so I'm gonna just briefly go over this. The idea really began in earnest in January of 2022, and I provide these to really show how quickly this came together. By May of 2022, again, still during the pandemic, there was a letter sent to the governor requesting support. And on the next slide, we see that that letter of support was received from the governor, Governor Sisolak at the time, in June. And since June, it has been a rapid building process among the different counties to make sure that all of the work was legally grounded, to make sure that the collaborative model was in place. You see in November, the Board of County Commissions began adopting ordinances which would remove their local health boards and join a health district within the community. And the first board meeting was in December after the State Board of Health approved the establishment of the Central Nevada Health District. January and February of this year has really been the focus on operationalizing all of these ideas. So getting through the policy work in the previous year and standing it up and moving towards that July 1st, 2023 deadline when it will be, I say fully funded, I should just say funded and operational. We're always looking for funding opportunities, and I want to thank our partners at the Division of Public and Behavioral Health, as well as the other districts in the state that have been such great advocates for standing this up. I've also provided an org chart on the next slide, which is, again, aspirational. It's where we will hope to build once we bring in the grant funding and the local contributions from the jurisdictions that support this in order to build out these capacities. Madam Chair, members of the committee, I'm more than happy to answer any questions you may have.
Thank you so much, and thank you for the quick wrap-up. We are pushing time here a little bit. Are there questions from the committee? Assemblywoman Gonzalez, please go ahead.
Cecilia Gonzalez, District 16 for the record. Thank you so much for your presentation. On the proposed organizational chart, I was just curious where mental and behavioral health would fall under. Thank you.
Thank you for the question. This is Caleb Cage for the record. So much like you heard from the other partners, the mental health and behavioral health are built into the various aspects of this model. It's something that the chair of our Board of Health has asked us to focus on, and we're bringing some materials to the next meeting in in March, in order to provide an overview. But it's done through partnership. It's done through building out these capacities and making sure that we are conducting the community needs assessment and making sure, or community health assessment rather, and making sure we're identifying where the behavioral health issues are, what they are, and how we can address them through these various opportunities to engage with the public, like public health nursing and a meeting with members of the public to advise them on health conditions they may have, joining the tobacco, I'm going to drop the name, I apologize, the Tobacco Coalition in the state to work on some of those issues related to health related to tobacco issues in the state and as well. So it's integrated throughout. It's not there's not a central node or a vertical here that speaks to behavioral health, though that is something we've been asked by our board to really make sure that we are integrating and to come up with novel ways to make sure we're addressing in our communities as well.
Thank you for that response. Are there any other questions from the committee? Well, you have quite the feat ahead of you. Good job and good luck. I did have a quick question. You mentioned tribal partnerships in one of your slides, but can you give us an idea of what that outreach and partnership could look like with the tribes within your jurisdictions?
Thank you for the question, Madam Chair. Caleb Cage for the record. Yeah, of course, a number of Nevada's 27 federally recognized tribes do reside or are located in these 4 counties. And we've been engaged in conversations on specific programs about managing state programs for these 4 communities that are within these areas and partnerships with the tribes. It's something that we think is critically important, and the relationships within the communities, usually county to tribal government, is well established and is an important part of the relationship. As we stand this up, we'll continue to seek opportunities to build those relationships. Right now, they'll come through public health preparedness and emergency management, but also through community outreach. And of course, as residents of these communities, tribal members will also have access to these programs. They'll be available to them as well.
Thank you. I'd be interested in hearing how those go. I know one of the issue areas that we've come across with sharing resources as a state with tribal governments is the interlocal agreement process that just doesn't quite fit the bill for those kinds of agreements. So keep us posted. Let us know if you need help. It is an interest area of mine. And I think that was the last question for you today, Mr. Cage. Thank you so much for being here. All right, last but certainly not least, we have the wrap-up, the home run hitter here, Megan Kumlasi. Thank you so much for being here today. We look forward to hearing from you on public health challenges and opportunities in Nevada. Please go ahead when you're ready.
Thank you so much, Chair Peters. Megan Kumlasi for the record. I am the Associate Director of the Center for Public Health Excellence within the School of Public Health at UNR, and I appreciate the invitation to be here with you today. You have heard a lot this afternoon about public health. You've heard 2 hours worth of information about public health, and that is just a drop in the bucket. I'm not going to spend the rest of the day talking about it, but I am here just to wrap up and pull out some key themes that we hope you take away from these presentations. You heard today about how governmental public health agencies work to keep Nevadans healthy, and how what we call public health really involves efforts to keep entire communities healthy. Public health entities look at the big picture at a wide range of factors that affect the health of the entire population of the state, and then figure out how to prevent or reduce the things that harm health and improve or promote the things that keep people healthy. I think one of the hard things in thinking about public health when you're trying to wrap your head around it is that it involves so many things, and they're things that we don't necessarily associate with the term health. But hopefully the presentations and the concrete examples that you've heard today really provide a foundation in what public health is and does, and why it's important, and why it's something that you might care about. I hope we've also done an okay job of clarifying that public health, the health of communities, and elevating the health of entire groups is different from the health that you seek as an individual in your doctor's office, or that your family seeks in a hospital. The other critical thing to reiterate is that when public health activities are working, you don't know or hear about them. We take the accomplishments of public health for granted, and many of us may not have even been familiar with the term prior to the COVID-19 pandemic. The field of public health has existed for more than a century, and it's evolved as science has evolved, and it continues evolving with scientific advances. But it's really something that happens in the background, and it's invisible, unless it's broken, unless there are issues to be solved. And even though it's invisible, it's important to know that it still has an impact on our daily lives, whether we realize it or not. But in your role as state policymakers, it's really important that you understand what public health agencies and practitioners do, both in your communities and across the state. The health of your constituents and the health of Nevada's economy depend on having strong public health systems that keep our communities safe and healthy during normal times, and that are well equipped to handle emergencies when they arise. If we could leave you with one thing today, it is that healthy people are productive people, and productive people create a strong economy. So on that note, we're just going to review a few of the challenges and opportunities that we've heard about, and I'm going to roll through these quickly because you've had so much on this already. But really, public health challenges and opportunities are really two different sides of the same coin. If you think about infrastructure and investment in public health, we're looking at physical infrastructure and funding, workforce you've heard about from all of the district health officers, and technology. Technology is super important in public health. It's a data-heavy field. We need that data coming in, and we need to be able to collect data quickly and share it. A lot of public health relies on old, outdated IT and data systems that don't talk to each other. And so data modernization is a focus of national, state, and local public health systems. Not something that we've heard about today and not something that we'll discuss more, but just important for you to be aware of. You've heard a lot about local administration of services today, the fact that we have this new Central Nevada Health District, and that there's opportunities to remove one word in statute that would make, if you saw the picture that Mr. Cage showed, there's one county in between the 4 counties that are part of that Central Nevada Health District. We need to remove the word adjacent so that they can be an entire health district rather than operate through other agreements. You heard a lot about accreditation, and so that's really just elevating the level of services that are provided. And then the last bullet on this slide is something that just wanted to touch on briefly. You've heard a lot about public health partnerships and working with the community. The public health sector essentially also partners with universities and institutions of higher education, and that's an opportunity to enhance collaboration and provide opportunities for academic research to inform public health activities, to develop a stronger public health workforce pipeline. You've heard a lot about workforce and pipeline needs today, and then provide opportunities for real-world experience for students at public health agencies. So essentially it's this win-win as we work to establish stronger relationships between universities like the UNR School of Public Health and the public health agencies that you heard from today, but that's something that we're working on as well. We're just going to hit home with public health funding today. If you haven't heard that public health needs more funding, then maybe you weren't here for the last 2 hours. But essentially, Nevada spends the least on public health per person of any state in the nation. Well, that's not true. It ties with Wisconsin. And the funding that it does have primarily comes from the federal government, and it's earmarked or directed to specific programs or needs or, services or crises or whatever. But essentially there is no flexible funding, or there is very little flexible funding for the folks that you heard from today to address whatever the public health crisis is of the day, whether that's monkeypox, whether that's COVID, whether that's congenital syphilis in Southern Nevada. There are issues that crop up all the time in public health, and if the funding isn't available, then these agencies are really challenged to respond because they don't have the infrastructure, the capacity, the funding to do it. So generally, just kind of big picture public health initiatives have a really great ROI. Investing just $10 per person per year in evidence-based programs, things like programs to increase physical activity or improve nutrition, can save the country as a whole more than $16 billion in 5 years. So that's an ROI of more than $5 for each $1 invested. The bottom line is the money that's invested in public health and prevention yields a lot on the back end. And then finally, as you invest in the public health system, it really benefits some of the most vulnerable populations in the state. So children, infants, folks in under-resourced communities, folks in Medicare, a little bit of investment in public health funding impacts them the most. Public health workforce, another issue you've heard about from everyone today. A recent analysis at the federal level estimated that state and local public health agencies nationwide need around 80,000 additional full-time staff to just provide those foundational public health services, or those core public health services that you've heard so much about. And as you heard in Nevada, Washoe County Health District has done a full FPHS analysis to determine that they need at least 24 FTE to provide those basic services. But essentially these agencies need to be able to serve their communities 24/7, and they have to have access to a wide range of data sources. They have to have robust lab capacity. They have to have emergency preparedness and policy planning capacity, and they have to have the expert staff they need to leverage all of those tools and resources to protect the public health, to keep communities healthy. And the emphasis here is on staff, because without staff, none of those resources that they have would be usable or used. And without public health practitioners, the system doesn't function. So the fact that Ms. Aker has 7 hard-to-fill positions that they just can't fill, that they're missing a community health nurse, that means that there's not a person in the community in the Carson City area or the greater Quad County area who's providing those direct services that public health provides. The fact that, I think in the governor's first executive order, he indicated, or maybe it was the second, there's a 24% vacancy rate at state departments, and that could probably include DPPH, means that there are not people providing the services that need to be provided to elevate the health of all Nevadans. So workforce is a very important resource within public health. The other piece is that the lack of funding connects to the public health workforce. The lack of consistent investment in governmental public health services has resulted in a 15% decrease in staffing, according to this national report. So not having funding equals people operating at, more than a full-time job, and leads to burnout and other issues. The 2021 Public Health Workforce Interest and Needs Survey, which is a national survey of the public health workforce, found that generally the COVID-19 pandemic exacerbated existing public health workforce shortages. No surprise, these were the people who were on the front lines of the pandemic, day in and day out. And this survey found that nearly a third of the public health workforce is considering leaving their organization in the next year. So not only can we not get enough people in to work in these agencies, but there's a lot of turnover. You heard a lot about recruitment and retention and hiring. 50% of this national survey indicated they're considering leaving due to pay. We know that in Nevada, pay for state folks, state employees, tends to be lower than that at the county level. So there's some challenges there with, the counties have trouble getting folks in the door, and the state has an even harder challenge because their pay is lower. 41% are considering leaving due to work overload and burnout. Again, a lot of these public servants who you've heard from today do multiple people's jobs. I'm not sure how they do all that they do in a day. They and their colleagues just are over capacity. Other reasons for considering leaving: opportunities for advancement, stress, and the pandemic. But so bottom line is workforce is an issue, and it needs to be addressed. So why care about public health? And I hope what these presentations have helped make the connection to today is that no matter your priority, it relates to public health. If you care about access to care, if you care about behavioral health, if you care about having children ready to learn so that they can get an education, if you care about economic development or environmental issues or clean air, or if you care about maternal mortality or the opioid epidemic, then you care about public health, because public health addresses all of those issues and can help move the needle on them. Healthy people are productive workers. Productive workers lead to a stronger economy. If you want a financial reason to care about public health, it is that if you improve the health of Nevadans, you reduce the cost of health care through the Medicaid program and the CHIP program. The state pays for a large portion of the population's health care through Medicaid, and if we can increase the general health, reduce the number of chronic conditions and issues that people have that cause costly care, then we save the state funding. So if we invest in public health, we reduce the cost of Medicaid on the back end. Finally, just this last point, investing in robust systems that detect, prevent, and address public health threats is more cost effective than responding to public health emergencies. So if we have strong public health infrastructure, if we have the capacity to address the needs of the day, if we have the workforce that can implement all of the services that you've heard about today, then when the next crisis emerges, we're better prepared. We have less sick people, we have less lost work days, we have less death, and the state is better off. So your role goes back to Ms. Peak's slide with those bubbles. The biggest orange one was policy. Policy is one of the strongest levers to improve public health. And a lot of the greatest public health achievements in the last 100 years involved policy change. So if you think about seatbelt laws, that's public health. Tobacco control and issues to improve maternal and infant health, all public health. So the policies that you pass matter, and they have huge impacts not on individual health, but on the health of the entire state, of everybody who lives here. So I would just encourage you to consider how improving the health of your community and communities in Nevada can help you achieve your legislative priorities. And then think about how understanding what the folks that you heard from today, what public health agencies and practitioners do, will help you evaluate and make decisions about opportunities to improve the health and well-being of your constituents. This brings us to SB 118, which is being considered this legislative session. It was sponsored by the Joint Interim Standing Committee on Health and Human Services, came out as the result of the last session's SB 209 study, which looked at the COVID-19 response and how to improve public health emergency responses in the future. Essentially, this bill would establish a fund with non-categorical funding, so this is flexible funding that could be appropriated or used to whatever local health districts and authorities needed to address the biggest issues or infrastructure needs of the day. It would appropriate $14 million per year of the biennium to local health authorities on a per capita basis. And the idea of the $15 million came from about $5 per capita. So 3 million people in the state, $5 per capita. If the state invests $5 per person in the state, then we improve public health drastically. And then that second bullet, or the third bullet, really is removing the word adjacent, so that the Central Nevada Health District and other like-minded and collaborative counties could create health districts even if they're not contiguous or adjacent. This is one huge public health bill that you will hear this session. And there will be numerous additional bills that you hear about that relate to public health on all of the topics that we've discussed today. But if we leave you with one piece, it's you heard about all the challenges that these folks and the public health authorities are facing, and this bill aims to address it. $15 million looks like a lot, but it's literally $5 per person as an investment. And if you think back to that slide on ROI, every $1 of investment results in a $5.60 return on investment. We invest the money now rather than putting it in a piggy bank to address the future, a future public health crisis. So that is it from me. Appreciate all of your time today, and I'd be happy to answer any questions.
Thank you so much, Ms. Kumlasi. I appreciate such the in-depth and wrap-up on information presented today. And thank you again to all of our presenters. I have a couple of questions for you, if you don't mind sticking around. Assemblywoman Thomas, please go ahead.
Thank you, Madam Chair, and thank you again for the presentation. I guess my question would go back to slide 3. When I was looking over this information, and I went to the rankings of each state, and I'm glad that you did correct that Wisconsin is, we're walking hand in hand with them, so we're not alone in being last. But anyway, my question actually has to do with research. Has anyone researched the fact that the District of Columbia gets $874 to their people? They're the largest, even though you put in here Alaska being the largest. District of Columbia is actually the largest. And I was wondering, how do we assess that they can get that kind of funding, but we can't? We can't even measure up to the U.S. average.
Sorry, this is an interesting question, and I just want to make sure that we address both the state obligation or the local obligation, what's put towards it as a state body versus the federal obligation, which is what we as a state have pretty much relied upon for at least a decade or more. If you would, thank you.
Thank you, Madam Chair. Megan Kumlasi for the record. I think there's a lot that goes into this, and DC is different because it is not a state, and so I'm not familiar with their exact funding, but we'll see if Ms. Peak has more. Julia Peak for the record. There's a few reports that look at overall state public health funding. So the one we're looking at is the Trust Fund for America's Health and America's Healthcare Ranking. Happy to provide that to the committee if they want to review it more closely. We provide data on that. As the chair mentioned, the state investment, we do okay on federal investments, but the state investment is really where we fall short. We have some categorical state general fund that goes into this. We have some funding for Women's Health Connection that does breast and cervical cancer screening. We have funds for the Account for Family Planning. Each of those are a few $1,000,000, but when you look at the investment, I mean, that could be $1 per capita, right, when you start looking at that specific investment. But where we fall short when you look at this report is really the state investment in public health. These reports also pull out where we rank on federal investment, so it's very interesting. Happy to provide it to the committee staff.
I think that would be really helpful, especially in understanding where maybe our state obligation has fallen flat. We also, just as a brief side note, have a limitation on revenue coming into the state. And so our pot is only the size that it is. And so when we look at what is our state investing in, it is looking at the variety of services provided through the state, not just isolated to Health and Human Services, but also education and aging and disabilities and other areas that are not specific to our public health districts and the public health services. I have Assemblywoman Taylor with a question.
Thank you, Chair. And thank you for your report. It's very, very informative. I have a question on slide 4, just a clarification. According to the study that you mentioned, the De Beaumont Foundation, there are an estimated 80,000 additional full-time staff. Is that for our state or across the country?
Thank you. Great question. Megan Kumlasi for the record. Yeah, no, this was a national study, and so it's 80,000 full-time staff for state and local public health agencies across the nation. Yeah.
Cumulative number
Yep.
across the nation. Okay, I thought so. Thank you very much. Thank you, Chair.
Thank you for clarifying. I'm sure it was on the website, but I want to make sure we got that on the record, so thank you for asking. So you touched on it just a little bit, Actually, I don't need to rehash it. I was going to ask about the state funding piece and like how that played a role in the overall funding, and I think you answered that sufficiently, so I appreciate that. Are there any other questions from the committee? Well, thank you all so much for your time here today. This is a dense topic area, but of importance to all of our constituents, and I think of growing concern for all of us as we're looking towards what do we want Nevada to look like in the next biennium. So appreciate your time today. Well, that wraps up that agenda item. Our last agenda item is public comment. We ask that public comment be kept to 2 minutes and please avoid repetition of comments made by the speakers previous to you. Staff will be timing each speaker during public comment to ensure everyone is given a fair opportunity to speak. If you would clearly state and spell your name for the record, that would be appreciated for our recording purposes. We will begin with public comment from those in the physical locations. I will start here in Carson City. Is there anyone in Carson City who would like to have public comment today? Is there anyone in Las Vegas who would like to come forward for public comment today? Seeing none in the physical locations, I would ask broadcast services to please add anybody on the call-in line who may be there for public comment.
Chair, the public line is open and working. There are no callers at this time.
Thank you so much. We'll go ahead and close that agenda item. Before we adjourn, are there any comments from the members? Thank you all so much for your time today. I know this was a long meeting, but I think that this essential information will help us as we process bills moving forward. I do want to give you all a heads up when we will start hearing bills at least next week, if we can't get one scheduled by Friday, but you will see that on the agenda as they're ready for you. And with that, excuse me, our next meeting will be Wednesday, Friday the 15th at 1:30 p.m. And the meeting is adjourned.